Hello, my name is Kate Chesterman. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. You can find us on all major podcast platforms, including Spotify and Apple and Google Podcasts. Please follow us to receive notifications about new episodes. And if you like what you hear, please consider leaving a review to help other listeners find us. You can also visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Today, I'm going to be discussing hiccups. Hiccups are caused by inspiratory muscle contractions that repeat several times a minute. The contraction results in a rush of air into the lungs, causing the glottis to close and producing the distinctive hic sound. Acute hiccups, defined as those lasting less than 48 hours, are usually benign and self-limiting. They're commonly caused as a result of gastric distension from swallowing air, excessive food or alcohol intake, or the consumption of fizzy drinks. They can also be caused by irritation of the GI tract from smoking or spicy foods, by sudden changes in environmental or GI temperatures, for example hot showers or drinking hot or cold beverages, as well as by sudden excitement or stress. Persistent attacks lasting more than 48 hours, or intractable hiccups lasting longer than a month, are a more serious phenomenon and often pose a diagnostic dilemma. These attacks can cause significant morbidity and have been associated with dehydration and malnutrition, gastroesophageal reflux disease, weight loss, cardiac arrhythmias, fatigue and insomnia, depression, and a reduced quality of life. Persistent hiccups are more likely to result from an organic cause affecting a component of the hiccup reflex. More than 100 causes have been described, and these can be classified as peripheral, central, metabolic, drug-induced, and psychogenic. In many cases, however, the cause remains unknown. Peripheral causes result from irritation of either the diaphragmatic, phrenic, or vagus nerves. Diaphragmatic or phrenic nerve irritation may result from conditions such as subphrenic abscesses, hepato or splenomegaly, hiatus hernia, esophageal cancer, an MI or pericarditis, or even an aberrant cardiac pacemaker wire. The vagus nerve is the longest cranial nerve in the body, travelling from the brainstem down through the neck and thorax and into the abdomen. Because of this, there are a wide range of possible underlying etiologies, including a foreign body or hair irritating the tympanic membrane, pharyngitis, laryngitis, goiters or neck cysts, intrathoracic pathologies including pneumonia, asthma, lung cancer and esophagitis, and intra-abdominal causes that can range from gastric cancer, gastritis and duodenal ulcers, to pancreatitis and pancreatic cancer, abscesses, bowel obstruction, inflammatory bowel disease, appendicitis, and prostatic disease. Central nervous system pathologies that can result in persistent or intractable hiccups include structural lesions such as intracranial neoplasms or MS, vascular lesions including hemorrhages, infarction, or AV malformations, as well as intracranial infections, trauma, and epilepsy. Metabolic causes include uremia, hyponatremia, hypocalcemia, and hypokalemia, as well as diabetes, gout, and hypocapnia and alkalosis. Drugs that can cause chronic and distressing hiccups include alcohol, diazepam, dexamethasone, antiepileptics, dopamine agonists, and opioids, and chemotherapy has also been reported to cause recurrent episodes of hiccups in some patients. Finally, some psychiatric conditions, such as personality and conversion disorders, as well as shock, grief, and fear, have been reported to be associated with prolonged symptoms. Because of the vast number of possible underlying etiologies in cases of chronic hiccups, a thorough clinical history and physical examination is important to allow for focused investigations. It's helpful to ask about potential triggers as well as the duration of the episodes of hiccups. Do the hiccups continue when the patient is asleep? If they don't, then a psychogenic or functional cause such as aerophagia should be considered. Are there red flags such as fever, night sweats, or even weight loss? Weight loss, for example, could be due to the hiccups themselves or could indicate an underlying serious pathology. It's also important to do a thorough systems review to explore symptoms that could indicate the origin of the hiccups. So ask about respiratory, cardiovascular, gastrointestinal and neurological symptoms, as well as exploring any psychiatric symptoms or history. The patient's past medical history and the knowledge of any chronic diseases may reveal a likely source, and it's also worth exploring their drug history to look for iatrogenic causes. An ENT examination to look for foreign bodies or aberrant hairs in the ear canals and the presence of pharyngitis, and to palpate for goiters, cysts or cervical lymph nodes should be undertaken. The chest should be examined to look for signs of asthma, chest infections or tumours, as well as arrhythmias and unequal pulses. Abdominal findings could include tenderness or organomegaly, aortic aneurysms or masses. Neurologically, it's advisable to check for focal lesions. The need for investigations can then be guided towards suspected abnormalities. In most cases of persistent or intractable hiccups, a blood test is indicated, and checking a full blood count, Usinase for electrolyte disturbance and uremia, calcium, LFTs and amylase, and a CRP would be considered a sensible first step. A chest X-ray and ECG may also be prudent if suggested by symptoms or examination findings, or if there is no obvious underlying cause. Further investigation would then be directed by the history and examination findings and the results of those initial investigations, and may include pulmonary function testing, further imaging such as a CT or MRI of the brain, or a CT of the chest, abdomen and pelvis, or an endoscopy. A referral to secondary care may be required if concerning underlying conditions or malignancies are suspected, and the urgency of this will be guided by your concerns and the need for immediate investigation or management. Secondary care investigations can include, among others, toxicology, lumbar punctures, and urgent imaging. Any management plan should consider the severity, duration, and the impact on the patient's quality of life, as well as any possible underlying cause. Hiccups are a common symptom that will often stop spontaneously, and they only warrant medical intervention if they become persistent and bothersome. Acute hiccups, which are often a source of amusement rather than distress, can be managed by avoiding triggers and with some self-help remedies, including breath holding, the Valsalva manoeuvre, breathing into a paper bag, sipping iced water, compressing the diaphragm by pulling the knees up to the chest, swallowing large amounts of water while holding the nose, and a sudden fright. As a result, patients rarely trouble medical professionals with these short-lived symptoms. For those with persistent or intractable symptoms, self-help remedies can also be tried. If these are unsuccessful, then hiccups may cease with treatment of the underlying cause if this can be identified. Depending on what this cause is felt to be, the patient may need to be referred, and again the urgency of this will depend on your clinical judgment. If a less serious cause, such as gastroesophageal reflux or gastric distension, is suspected, then the management of this may well be possible in primary care, for example with the use of proton pump inhibitors, prokinetics such as metoclopramide, antacids or peppermint. If the treatment of the underlying cause is unsuccessful, or if there is no clear underlying cause, then second-line treatment options include alternative therapies such as acupuncture, hypnosis or psychotherapy, or attempts to interrupt the hiccup reflex arc through physical manipulation. This can include techniques such as stimulating the nasopharynx or lifting the uvula with a cotton swab, or even with vagal manoeuvres such as carotid sinus massage. These procedures are not without risk. Vagal manoeuvres, for example, can result in severe bradycardia, and so they should only be performed by those with appropriate expertise and when less invasive measures have failed. In terms of the pharmacological management of hiccups, unfortunately, most of the evidence comes from observational studies and case reports, and we're lacking large randomised controlled trials and consensus statements. Because of this, pharmacological treatments are usually reserved for those rare cases of persistent hiccups that are resistant to non-pharmacological management and are used to try to reduce associated distress and prevent complications, and these treatments are usually initiated by a specialist physician. The use of baclofen is supported by 2 small randomised controlled trials and is often considered first line if the patient has adequate renal function. There is some evidence for the use of oral or intravenous chlorpromazine and metoclopramide, although their use may be limited by side effects. And there is also some evidence for the use of gabapentin, nifedipine or haloperidol, but again more trials are needed. In some patients, combinations of treatments may be required, and again this can be guided by secondary care as their benefits need to be balanced against potential side effects. It is worth being aware that benzodiazepines can precipitate or exacerbate hiccups and should therefore be avoided. In patients with hiccups that are resistant to all the previously suggested treatments, a referral for phrenic nerve disruption may be considered as a last resort. So finally, how would we manage hiccups in a palliative care setting? This is an important consideration, as we know that 4 to 5% of patients with advanced cancer are affected by persistent and distressing hiccups, and this can cause a great deal of physical and emotional discomfort. Well, again, we want to consider the likely underlying causes, and this will help guide our management. Gastric stasis and distension, as well as reflux disease, are common in the palliative care setting, and treatment with peppermint, antacids containing simethicone and PPIs can be very effective. Prokinetics such as domperidone and metoclopramide can also relieve symptoms and can be added if required. It's worth noting, however, that we should avoid prescribing peppermint and prokinetics together, as they have opposing actions on the esophageal sphincter. Metabolic disturbances such as uremia, hypercalcemia and hypomagnesemia are not uncommon findings in palliative care and should be corrected if possible. And if an infection is felt to be causing the hiccups, then the appropriate treatment of this may lead to a resolution. Our local palliative care teams can offer invaluable advice and support, and an early discussion with them can be extremely beneficial. They can advise, for example, on whether the use of dexamethasone would be appropriate to try to reduce nerve compression or irritation from hepatic, mediastinal or cerebral tumours, and they can also guide us regarding the possible use of other medications such as baclofen, haloperidol, levomepromazine or nifedipine. Whichever treatment we opt for, it is important that we review within a few days to ensure that symptoms are settling and to try an alternative if they are not. So, thank you all for listening. I hope you found this podcast helpful. Please do have a look at the show notes that accompany this episode at GPnotebook.com. Feel free to email support@GPnotebook.com if you have any questions, comments, or ideas for future podcast episodes. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts which are designed to help make your lives a little easier and ultimately help improve the lives of our patients in primary care.